Good morning and welcome. I'm Sarah Weatherson, she, her, white woman with gray and brown hair and glasses, and I'm the lead staff for the Medicaid Advisory Committee, or the MAC. This is the MAC's public meeting for September 2024 to help fulfill its federal and state mandates to advise both the Oregon Health Authority, or OHA, and the Oregon Department of Human Services, or ODHS, on how to run Oregon's Medicaid program. So I'm going to share a few logistical announcements. Although I'm seeing things come in the chat, let me just check in about this. There's a request for the ASL interpreter to turn on their video. So I'm sharing that. And back to our logistical announcements, we're asked that folks mute themselves if they're not speaking. If you're joining by phone, please mute yourself if you're not speaking, and please avoid putting the meeting on hold. If you have to leave for some reason, go ahead and hang up and then rejoin the meeting later. And then MAC members will ask you to use the raise hand button if you have a comment or a question, or put a note in the chat. The Medicaid Advisory Committee has built-in time for discussion after each presentation. MAC members will speak first. When we've exhausted questions from MAC members, if there is time remaining for agenda items, we'll take general questions. We've also left 10 minutes for public comment near the end of the meeting. We do have ASL and Spanish language interpretation available for today's meeting, and you can pin the ASL interpreter's video by clicking the More button next to their name. There's also a button for interpretation, which is where you will find the Spanish language interpretation at the bottom of your Zoom screens. I'm going to hand it off to our chair, and I will note that she has sent me a message saying that there weren't meeting minutes attached to our latest email to our members. And so I'm going to quickly drop a link to that in our chat in case other folks have not received the meeting minutes. I think let's do that. So this link that's just coming across now is a link to our meeting minutes, so that members will have those to look at. And with that, I will hand it over to our co-chair, Caroline Barrett. And if Caroline will take us through our meeting, that would be great.
Good morning. I'm Dr. Caroline Barrett. This is my first meeting I'm leading as co-chair, so bear with me if I bumble at all. Thanks, Sarah, for putting in those minutes. I'm not sure if anybody else saw them attached, but I didn't see them this morning. So welcome everyone, committee members, members of the public. So we'll start with roll call. Obviously I am here. This is my first time pronouncing some of these names, so if I am mispronouncing, please correct me. David Lima.
David sent me an email this morning saying that he wasn't feeling well and would not make this meeting.
Right, hope he feels better soon. Gabe Triplett. Okay, we'll circle back to Gabe at the end again. Heather Jeffress.
Present.
Good morning, Heather. Looks like Hillary is an excused absence. Jerry Weeks. Okay, Kaya Adams. Kelly DeVore.
Good morning, here.
Good morning. Laura McKean.
Good morning, I'm here.
Good morning. Lisa Pearson.
Here.
Good morning. Ronnie is an excused absence. Shannon Buck. Dr. Tony German.
Good morning, everybody present.
Good morning, Tony. Peter Starkey. So circling back, Gabe, were you able to join? Jerry, Shannon? Shannon's on the chat, great.
Hi, Caroline. This is Jerry Weeks. I'm here.
Hi, Jerry. Sorry, I missed you if you said something. Do we, Sarah, do we have a quorum?
Yes, we have 7 members present, so we do have a quorum.
Wonderful. And thanks, Shannon, for letting us know you can't unmute today. We'll make sure to look for your comments in the chat. So just want to remind all of the members of the consent agenda, which we discussed this spring, which we'll be sharing at every meeting going forward. Those were sent out just Monday. So please in here that is, so take a moment to look at that. And while we're looking at that, if committee members could please take a moment and look at the minute meetings from June. And if there are any corrections or things that need to be changed. Am I the only one who didn't see this before, or did other people have a chance to read this more thoroughly?
It just came out.
Okay, so let's give it a couple minutes to read through this then. Not sure how fast people are at scanning. Do people want more time?
I can be ready to motion to approve if folks are ready. This is Kelly DeVore.
I can second that, Tony German.
Great. Thank you. If there are no, okay, so yes, any objections? Abstentions? Okay, the motion carries. And so we are moving on to the health-related social needs benefit implementation update. And this is a MAC identified priority area. The team from OHA will outline what data is currently available for implementation of the HRSN benefit. And they will help we'll have a discussion about what MAC members would like to see in an ongoing evaluations of the HRSN benefits as they are rolled out. And so the members of the OHA's Health Policy and Analytics, HRSN, and Health IT Analytics team are here to present. Thank you for being here. Andrea Kraus, can you please introduce yourself and let us know who's with you today?
Yeah, I believe I'm Andrea Kraus, she, her. I'm the quality improvement analyst here at OHA, dedicated to the waiver. And I'm going to hand things off to Anna Menon, who will take over the rest of the introductions.
Thanks, Andrea, and thanks, Caroline. Thanks for having us today. My name is Anna Menon. I am the health-related social needs analytics lead on one of our teams working on the waiver. And I'm just going to pass to our other team members so they can introduce themselves briefly. Ava, if you're here, go ahead. Ava might not be with us today. So Deepti.
Hi, good morning. My name is Deepti Shinde. I'm a part of the monitoring and evaluation team in health analytics, and my title is evaluation advisor. And I will pass it off to Elliot.
Good morning, everyone. Elliot Moon, he, they pronouns. I'm the waiver monitoring research analyst within the monitoring evaluation team, part of Deepti's team as well. Yeah.
Thanks, Elliot. We can go to the next slide. So we just did our introductions. We are going to bring you through a brief project background and purpose. And then we really hope to spend most of our time with you today on some reflection questions and getting feedback from MAC members on your own goals and priorities and what you hope to see from this ongoing waiver analytics work. And then we'll wrap up with some next steps. Great, and we can go to the next slide. So for project background, we just introduced ourselves with our titles and our teams, but if that doesn't mean anything to you, we are members of 3 teams at OHA that are working together to produce data summaries and reports on the health-related social needs services, really for all types of audience, internal, external, community members, CCOs. We are the Social Health Needs and Analytics Projects team. We go by SHNAP for short. And we do data for the public and internal program evaluation. Elliot and Deepti are on the monitoring and evaluation team, which is really focused on the federal monitoring. So from the CMS, the Centers for Medicare and Medicaid Services, and the official evaluation that's going on, which I think MAC already provided some feedback on. And then Andrea is on the quality improvement team, so tracking quality measures to help improve internal programs. And I think you're all, oh, Heather, go ahead, I see a hand.
I apologize. I know you have time for questions later. Can you please explain which or describe which part of OHA you are part of on your team? Like where do your teams reside? Are you in Medicaid? Are you in health IT? Are you in behavioral health? There's so many divisions at OHA that would be helpful in the context.
There's so many divisions, that's right. So we are in the health IT and analytics, but our teams sort of straddle health policy and analytics. So we go across those 2 teams. Great. All right, so HRSN, and I think you should all be familiar with this, but just as a little refresher, health-related social needs, the social and economic needs that impact an individual's ability to maintain their health and well-being. So our HRSN, when we talk about that, we're talking about really our work in the climate modification device space, housing, and nutrition benefits. And then we also have the outreach and engagement benefit. We can go to the next slide, please. Great. So we have plans to collect a variety of HRSN services data to support our work in the demonstration waiver. So we're planning, just to level set what kind of data, we're planning on collecting HRSN service utilization, so information on members receiving services, so who's receiving services, what services are they receiving, that kind of information. HRSN requests, so who is requesting services, how are they being routed to the HRSN program? Are they coming through community-based organizations? Are they being contacted by CCOs? That kind of information. We plan to collect denials, appeals, and grievances. So who is being denied services and why? And then who's appealing those denials? And then if there's any grievances filed, we would be tracking those too. Care coordination and closed loop referrals. So when members are referred out for services, who is accepting or declining? And how is communication coming back to the plans? So the HRSN benefit has an interesting setup where some of the services will be provided by community-based organizations, or other community organizations. So it's really important to track that flow of information from the CCO or open card to the outside organization and then see what comes back. We will also be collecting information on the provider network. So those providers who are going to be providing the services. So what organizations have enrolled as providers, how are they working with CCOs, how are they distributed geographically? And then finally, HRSN financial information. How much is it costing? Any questions here on the data we're collecting? Heather, go ahead.
Just a clarifying question. All of that information is coming from the CCOs directly to you, or how will that, I guess just a little workflow, like I have assumptions about how that's working, what you just put on the next slide, which was a great description, but I just want to make sure my assumptions are correct.
Sure, yeah, so yes, all of this information is going to be coming from CCOs. Now the CCOs are going to be collecting some of it from providers, right? The care coordination, closed loop referral, that's going to be really the provider's responsibility for documenting most of that and then sharing it with CCOs.
And will the grievances come directly from the CCOs, or will you collect those also from ombudsman, providers, and individual consumers in some way, or will that process go through the standard denial and appeal process through the CCOs?
So both, really. We have like the formal grievances that we're collecting through the Exhibit I document. And then we are also tracking and are meeting with the ombudsman and trying to understand like broader complaints that are happening. Thanks for the question. Tony, go ahead.
Yeah, just a quick question about the definition of providers too, in the context of clinical settings, but also community-based organizations. Do your guys, could you just talk a little bit about that?
About the providers?
Yeah, our definition of, because a lot of HRSN also is coming from community-based organizations and connections through that. Just wondered if you could spell how that's working in your guys' relationship with them.
Yeah, and just when you answer that, you might check the chat. There was a question from Shannon that's related to Tony's question.
Okay, thanks. So to be an HRSN provider, you have to either register with a CCO or register with the state. So we are tracking those kind of provider relationships, and it's a really broad term, right? So we have culturally specific providers, we have community health workers, FQHCs could be a provider. It's a really broad term on purpose, and we do need that. We're in the process of registering them right now. So you can register through the state and provide services through any CCO or open card member, or you can register directly with a CCO and provide HRSN services just for that CCO's member base. And
so to answer Shannon's question, does that mean they should apply with the state if their local CCOs are closed?
That's really interesting. So there are some CCOs saying that they have enough providers. I have not heard that. Yes, I would encourage those providers to register with the state. I'd be really curious to hear more about that experience. So if you could connect us if you've heard any more details about that.
Heather.
Thank you, Caroline. Yeah, that was why I asked about the complaints, continuous feedback, grievance, whatever we would like to call it, process for consumers and providers, making sure that we have opportunities for quality improvement as we roll out the process, because there are things like that occur. And I think that was an excellent example that Shannon just shared.
And Lisa just put in the chat that Lisa's in Benton County, that their CCO has turned off new behavioral health providers on several occasions.
That's great to know, Lisa. Thank you.
Curious, though, sorry, I just want to jump in. I'm curious though, this is specifically about HRSN service providers, which is different than a behavioral health provider, primary care provider. This is a much broader type of provider. And from a CCO, I would be really surprised about turning any of them off because we're still standing them up. We are currently in the process of contracting to try to develop that network.
Thank you, Kelly.
Thanks, Kelly. Yeah, so if I would, that also surprised me if any HRSN providers have been turned off, if that process has been turned off with the CCO. But if that is happening, I would be really curious to hear about it. So please, we have our contact information on the last slide. Please route them to us. And then also encourage those providers to register with the state because they would still be able to provide services. All right, I'm going to move us on to the next slide. Okay, so our purpose, our little group here, the data planning project, is to develop a clear plan for routine collecting, analyzing, and reporting on HRSN data. We are trying to build an initial set of goals and objectives for HRN services developed with input from a wide variety of interested parties. The MAC being one of those interested parties we're hoping to get feedback from. So this plan is going to be a living document that we will be updating as we engage with more groups, as we get more feedback, as we understand the progression of this benefit. And I just really want to call out that this is separate from the CMS evaluation work that I know MAC has already given input on. So this is something that we're doing in-house. It's thinking about like continual improvement. It's thinking about what data products we are putting out in the world, how we're communicating how this benefit is going. Any questions here? Okay, next slide, please. Okay, so what we expect to do after this meeting is to incorporate all interested parties' viewpoints into our analytics work, plan for HRSN data analysis and reports that will be useful and relevant for external groups such as yourself, and to raise awareness and level set about what data will be available and when. Next slide, please. Okay, so this is just a list of the groups and or individuals we've already talked with. We've engaged with program leads and other key waiver team staff, the Ombuds program, innovator agents, the waiver community engagement team, and the waiver health equity staff work group, Medicaid fee-for-service team, and the teams responsible for community partnership, engagement, communications, and government relations. Next slide, please. Okay. So today, we hope that you can help us plan for HRSN data summaries, reports, and interactive data displays, dashboards, by gathering your thoughts on your hopes for HRSN, how equity and community voice can be incorporated into HRSN data analysis and reporting, and what you would need to know to understand if the program is working as it should. Next slide, please. And I think I'm going to turn it over to Andrea to lead some of our discussion questions.
All right. Hi again, everyone. Can we go to the next slide, please? All right. So our goal for today is really being able to have an open discussion with you all and hear your viewpoints, your hopes and thoughts on how we can monitor and produce data for HRSN. Heather.
Thank you. Before we dive in, just asking for a clarifying question, could we have a reminder of the eligible population for HRSN for the CCOs and what that guidance is for the committee members so that we can frame our questions around that eligible population and our equity interests and all that good stuff?
Absolutely. That is a complicated list. I'm going to ask if one of my teammates will work on posting that into the chat. Thank you. All right.
That is why I asked for clarification, because we've heard over the months, we've heard the evolving eligibility. And so it's good to have a reminder of where we landed. Thank you.
Thanks, Heather. I just put it in the chat.
All right, so our questions are going to be asked by myself and then also posted in the chat. So for our visual and auditory learners and processors. And our HRSN data team will be taking notes. And what I'll just ask is if you want to chime in, raise your hand and we'll do our best to hear from everyone. Next slide. All right, so our first question for you is, given the full breadth of your experience, what are the results you hope to see from the HRSN benefit program? And as you think about that, we ask you to kind of, imagine the future here, first of all, 6 months after launch and then 2 years, and really picture how you would know if we achieve those results. So what would you see in reports or media coverage? What would you hear from others? What would you hear in a presentation as we came back? So yeah, I'd love to hear what you're hoping to see. Caroline.
As a first thought in terms of 6 months after launch, I think an important starting point is awareness and marketing. In question about reports or media coverage, I think it's critically important to have this be widely dispersed, both through broader media coverage as well as with clinician groups who are serving these populations. So that would be my initial thought in terms of success within 6 months is significant awareness and of who is eligible, because I think that has been very muddy and many people have thought that this has a broader eligibility criteria than actually is the case. So broad knowledge of eligibility criteria, how to access the services, and then seeing people initially requesting these services.
Thank you. Heather.
I totally concur with Caroline and her comments. And perhaps I'm looking at the 7 eligibility criteria, and I have an understanding of why those may have been chosen. But along that line of like, as we think about where we are and where we want to move the needle, it would be really helpful, I think, for folks also to not only have those eligibilities, but to have the data behind why that eligibility criteria was chosen, so that we know what we're trying to move the needle on, and getting really strong marketing and clarity and understanding across not only the general public, but all of this entities that are part of the system of care. So like an example would be, I'm adults and youth released from incarceration. As a behavioral health professional, my understanding of that is I understand that people, upon release, they're in significant risk of traumatic relapse, death, chronic disease management that goes out of control, lack of housing. So I can rattle off those things. I know those things for folks coming out of incarceral. But if we can have some place where we know that's an outcome, so I would hope, in the next reporting period, we actually are tracking people who are Medicaid, OHP recipients, and that those who experience carceral settings have moved to stabilization more quickly. But I don't know, do we have a baseline? How will we track that? That's my question to you. So those are the kinds of things I'm thinking about when I see, because this is an amazing experiment, and I think CMS will be looking very hard at us if we actually have moved the needle on the reasons that we chose the eligible parties, along with what Caroline said, that I think there's still in the larger community a lot of confusion that this is a much broader eligible service than it is versus being a pilot.
Yeah, absolutely. And I think to address what data is available and what we will be able to generate, part of why we're having these conversations is to hear the things that folks are interested in and be able to explore those possibilities. So I think I can't answer that question directly right now. But part of our plan is going to be putting together a bit of a data development agenda as part of our plan. So things that we don't have an automatic plan for, like how can we get to that? And before I get to Tony, I just want to highlight Lisa's comment in the chat that it's concerning that even when staff are asked for the criteria, that there's not a concise presentation of those. I'm not sure how consumers are going to understand whether they're eligible so they can decide whether to invest the effort to apply. Thank you, Lisa, for that. And Caroline also said if it's possible to drop a link in the chat to a list of covered services, that would be helpful. So if I can ask Anna or Elliot to please do that. Tony.
Yeah. First off, thanks for this inquiry and for bringing this needed attention to this. I think studying an intervention that we're being creative in this state for, I think is necessary, an element. And I think our reflections on what we're trying to do for this 1115 waiver is trying to provide evidence for proof of concept. And I think we're all very optimistic by that. I think that the comment by Heather regarding a baseline is a really necessary element. And I know that this is a moving target and it's hard to identify that, but I think that's valuable in addressing what we'd like to see in data as outcomes, right? And so I think, when we look at this eligible population with this is trying as best we can to look at a couple different factors. So we're trying to prove that if we keep people in their homes or we provide them with an air purifier or climate-related interventions, does it lead to better outcomes for their health and well-being? So I think what I would take it back to is just the data analysis is to try to identify patients at baseline. And then look what objectively we can maybe tease out. So oftentimes these are proxies, but I think sometimes in this setting, just off the top of my head, and I think that this would be wise for us to continue to think through this and provide some thought on the spot. Sometimes hard to think of that. But maybe in that team for you guys to also prompt us to think of other ideas that you might have as a back and forth conversation. But I look at hospitalizations, I look at asthma exacerbations, I look at, related to smoke inhalation at baseline. What does an air purifier, air conditioner, does that have an impact on CHF exacerbations, COPD exacerbations, things that objectively that we might be able to tease out further with that. Hospitalizations related to heat related illnesses, or clinic visits, or augmentation strategies for inhaler uses. So these are just things I'm spitballing as I'm sitting here thinking through this, but I think some more time to think through that. Yeah, appreciate the thoughts.
Absolutely. And since Tony provided us such a great segue, just before I get to Laura, I want to invite folks to start thinking on that 2 years into the program, because I think a lot of these health outcomes, right, aren't something, a few things maybe we could look at the 6 months, but a lot of those are going to be longer term. Laura, what are your thoughts?
Hi, thanks, Andrea. And I don't know, I was thinking to myself, given the discussion, I just wanted to give a little bit of background on the CCOs and how they were awarded this funding to implement and partner with CBOs to do this. Each of the CCOs was awarded a certain amount to contract with these CPOs to provide these services. And I think it's just important to point out that there's pretty strict criteria for these CBOs to be considered getting awarded a contract to provide these services. And sometimes I don't think that information really gets disseminated to folks sometimes, but they have to be eligible as an organization defined by CMS. They have to submit a completed budget. So there's just things of that nature that the CBOs are required to do if they're going to be an HRSN provider. And just because I come from a CCO, we've been embedded in this work for many, many months now. So somebody just can't say to the CCO, oh, I want to provide these services. There's a pretty intense, detailed process that the CBOs and the CCOs must go through in order to contract to provide these services.
Thanks, Laura, for providing that context. Heather.
Thank you, Laura. That was super helpful. One of the MAC federal requirements is that we, as Caroline had mentioned earlier, that we kind of attend to Medicaid marketing and communications material. And I always thought that was a weird one, but we're finding actually it's really, really important and really hard. And so for everyone. And so I really appreciate and just want to add on to Laura that I think at this stage, in the early stage, as we're getting ready for outcomes, and I totally agree, Andrea, your team is doing a great job in thinking about these things, and that it really is a longer timeline because it's so new, 2 years out. But in laying that good foundation, another recommendation, not only communication, as Lisa said, to consumers, and as I mentioned, to other providers and stakeholders in the system that deliver care, but the eligibility criteria. I was not aware that it was such a rigorous eligibility criteria for our CBO partners. So that would be, and I haven't heard of any of my day job is a trade association membership for behavioral health organizations, and I haven't heard of any of our peer-run organizations talking about that application process. So my guess is where is that posted? How do people find it? Is it really transparent and clear for potential interested parties? And if it is such a process, that gives me hope, because then that means there's a way to collect good data on how many culturally specific, linguistically specific CBOs are engaged across the state, because there'll be data collected somewhere on them. So that's hopeful. I'm excited about that we can get some good data on the expansion of culturally and linguistically specific service providers in the state. I love that.
Great. Caroline.
With thinking on the 2-year line, I couldn't agree more with Tony about looking at specific health outcomes in terms of ER visits, hospitalization rates, asthma exacerbations, et cetera, heat-related deaths, et cetera. I also think it's important, if we're looking at this through the health equity lens, that we be collecting data on outcomes specifically with that subdata of people who are still having asthma exacerbations. What is the demographic breakdown? What are the other health inequities? I am curious how that subdata about demographic groups are going to be collected.
And I feel like there's so many questions, and we want to hear from you, and we want to provide the feedback.
Well, just to pause for a second, because we really only have about 5 minutes left in this meeting. Sarah, if you're able to collect some of the questions from today, if Andrea, your group could perhaps address some of those in written feedback afterwards, I think that is often a much better use of time and able to provide more thorough answers. So that I think is absolutely an option. But so yes, we just have a few minutes left. If you have a last question or last discussion people want to say.
Yeah, can we move forward? I think a couple. Let's jump to, yeah. So I think what I would like to close with is for a new question is thinking about the communities and partners that you're a part of and that you work with. What do you know or imagine that they would want to see from the program? And I think what I would love to hear from for you is the Oregon Health Plan members and their families and what you think they want to hear about how the program's working. Or I've certainly heard the clear communication about who is eligible. That is obviously a very key part of it. What are other things? Heather.
Sorry, my mute was having a little moment there. I just, as the other co-chair of the MAC, I just really would align with what Caroline just said. These are really great questions. Thank you so much for all the thinking. I know as people see questions, they're like, oh, questions. But I know there's a lot of thinking behind those questions to achieve your goals. And I would be willing as a member, and we do this frequently in the MAC, where if you can send us those questions and we'll take minutes and give them back to you because I think we all threw very complex questions and comments to the team here. So thank you for listening and hearing us. Then we can get that back to you. Do you have any timelines that we need to be aware of in responding to you, Andrea?
I'm gonna kick to Anna. What do you think about timelines for getting feedback? And this is, I mean, part of it is this is going to be a living document. So we're aiming to have a draft of our plan done by mid-October, but that also doesn't mean that feedback that would come in after that couldn't be incorporated, because we do consider this, we want a document that's an initial one, but we are going to continue to adjust and edit and change plans. So this is not going to be a static document for us. And that would be great if anyone would love to provide feedback. We will work with Sarah and make sure you get the questions in a way to channel that back to us. So thank you. I'm just going to kick over to Elliot, I believe, to let you know what we're going to do with this information you've provided with us.
Yeah, can we go to the next slide? It might be a couple. Oh, there it is. So next steps. So we will follow up on what has been what we talked about, and hopefully maybe we can get some feedback via written so we can incorporate that feedback too into the future plans. So we'll be creating a summary of what we've heard from this meeting and other meetings that we've been a part of where we've asked similar questions. When we'll consider what we hear through themes and kind of summarizing what we heard, and to develop data summaries and products in the future, as long as the analytic plan. And we'll be checking in along the way with the various groups to ensure that what we're working on and what we're incorporating is kind of matching what people have requested. And the next slide. Just want to say thank you so much for being here and answering our questions. And yeah, I know they're hard to answer and they're big questions and a lot of context setting. So we appreciate your time and trying to answer these big questions, and just want to provide our contact information if you all wanted to follow up. But it sounds like there's a want to provide written feedback too. So maybe someone can answer Tony's question, where will findings and summaries be shared? I think that might still be being figured out.
Yeah, so Tony, so this is going to be an internal document that really helps focus our analytics work. So I anticipate our group or the SHNAP team coming back to MAC meetings a couple times a year, maybe more, to provide updates and information on the program in general. And I can imagine at least the first one being us sharing what we heard from you and the direction of some of the analytics work, maybe in addition to some of the actual data products we're creating.
Well, thank you so much for joining us today. I know we all really appreciate being brought into the conversation as these documents are being developed so that we can help provide input as things are being created. So thank you very much for listening today, your thoughtful questions, and all the work we're doing. And we look forward to a future update from you. And we will work on getting a summary of our questions to you from Sarah. Thank you so much. So moving on, we are now heading into the public health emergency unwinding update. So this is our periodic update. Today, we will be focusing on the effects of the unwinding on enrollment in Medicaid. Emily R.E. Burnett, Senior Medicaid Eligibility Analyst from OHA Medicaid, will present. Emily, if you're ready to present, go ahead. And we have we're just a tiny bit behind, so we're doing great.
Great, thank you. I'd like to also introduce my counterpart who will be starting the presentation. Her name is Christy Jo Williams. Christy Jo.
Hi, thank you so much for having us and good morning. As Emily said, I'm Christy Jo Williams of she, her pronouns. I am with ODHS, Oregon Eligibility Partnership, as the Service Delivery Support Administrator, and I'm co-leading PHEU with Emily. So I'm going to kick us off on the background. We'll go through some information and have time for questions and answers at the end as well. But I'm going to do a pretty high overview since I know that David and Jillian and Megan has been presenting a lot of the background and the progress ongoing for the last, is it a year or more at this point? So just real quick level setting, right? So we started unwinding the PHEU, the federal requirements or the federal pandemic emergency ended May 11th, 2023. We began the medical renewals and really initiated across 22 months. We started with a plan for 10 waves. We did have to pause mid to late last year to really, or this year, sorry, I can't believe it's already 2024 in September, to really initiate the federal request to look at ex parte and passive renewal differently. So next slide kind of gives you an overview of the phases we went through and are going through for the unwind, right? So phase one, we really front loaded populations, groups likely to remain eligible. Really went into phase two of looking at those groups that we wanted to provide the maximum protection as well as a long runway to make sure we got their address and information and could contact them and they had the awareness that this was coming. And then really spent February of 24 through May working through the responses of those first waves and also initiating the changes the feds asked us to do around ex parte. We also had been holding some of the OSIP-M, TOA folks who are receiving OSIP-M to really be able to provide a different approach for them as well. So we initiated the last 4 months of the unwinding of the renewals in June and just initiated the last population that will go through the unwind and are working through that. Our last closure date as of right now is February of 2025. and we are working to make sure that our eligibility staff are really prioritizing the renewals in addition to new applications, and are trying to keep as current as possible, and recognizing that we will use some of 2025 to make sure that we have worked through all of those renewals. Next slide, please. So another reminder of just the steps we've taken in partnership with all of your feedback and our community's feedback in partnership with OHA and ODHS. The newest, the biggest advantage that came to us is creating OHP Bridge, which Emily will talk about more later as well. But really, strong outreach efforts. We continue to hope those billboards and those reminders of keeping your email and your phone number and your address up to date, because we still need to get in touch with folks. We're also doing some outreach efforts that, again, Emily can get into detail with as well. Also looking at how we can automate renewals, right? When things haven't changed, when you're pretty steady, how do we go ahead and help folks through the passive renewal? With the changes of ex parte, we have seen an increase in more active renewals. And I would say that's a good thing. It's been years since we were able to contact some of these individuals. And so an interview and finding out what's going on has been helpful. Unfortunately, right, some information means folks have moved. Well, fortunately, some folks have moved to other medical programs, but also some we are finding that are no longer eligible. But that conversation has been helpful, especially around helping them navigate their community services, right? So next slide, please. Renewal system changes. So I referenced some of the changes that we did in response to the federal requirements. So that's the first one, right? So we made a change around the passive renewals. It's ex parte is the other word for it, right? Having to fall in line to make sure that we are looking at the ability to passively renew at the individual level of the family household, not just the case overall, which has increased some of our active renewals. We also made a change where you are no longer, if you seem to be over income or over resources or no longer eligible, instead of terminating, we made a system change that you're getting an active renewal packet that hopefully is allowing us to engage and have that conversation, not only just to clarify what's going on, but also to provide that assistance with you. Also encouraging, more information, right, to make sure we get the information and make the best determination for you. And then we also did some improvements to our notices. I think there's always, this is where I will plug in continuous improvement, right? We continue to want to hear how this is going. What else can we do? I will overshare that because of the changes we made with our notices, CMS has actually encouraged some other states to come talk to us about some of the person-centered design that we used with our notices. So now we're having a single renewal notice, trying to make sure that although we need to tell someone what they are not eligible for and what they're eligible for, trying to really use more plain language, so we're not scaring people about, nope, you've been denied for this, but right, and really leading with, you're approved for this. Here are the things we also considered, trying to use language that I would understand if I didn't work in ODHS. And then also making changes to medical, the eligibility and the renewal notice. Again, trying to make it easier to read and to navigate. Next slide, please. All right, so here's the good news. We are so close. I said good news. It's good news in that we're getting to the end of the unwind. I want to preface with that it's not always good news, right? And I just want to be sensitive to the fact that this is, this never done this before, never done a public emergency, thank goodness. But also recognizing that some people are losing benefits and really weren't fully aware of why they had it and why they can't continue it, right? So, but we have initiated the majority of our renewals. We've had contact with these folks who are receiving medical as well as some food benefits. We are close to being completed. There is a sliver of orange which says not started that you actually can't see because it is so tiny. But there were situations during the unwind that we allowed exceptions in the system for individuals who may still have the unwind. We call it a flag in our system. It is approximately 4,000 cases, so families, households, that one individual at least in that household still has the unwind tag. We are working through how to initiate and make sure we have contact with those folks. So I just want to acknowledge that although this looks like we're almost at 0%, there is a sliver that we can't see because it's so small, right? And I just want to acknowledge that. But 94.5, we're almost there. And I see there's messages. Once Emily starts presenting, I'll go back and read those. I am not very good at talking to you and reading at the same time. And so give me a minute if you don't mind. Next slide, please. All right, so here is what we're seeing after initiation, after we have completed the renewal. These are the results we're seeing. Over 1 million renewals have been completed. 82.5 of those percentage-wise has continued at their same benefit level. 16.3% have had benefits ended. Anecdotally, we've had some conversations with folks who have lost benefits, and there are stories that I think encourage all of us to continue to look at other medical programs that we could launch in Oregon. But there's also been some great stories of like, yeah, I finished my education and I'm now employed and have private insurance. And, it's a mixture of both of those things. The other thing I want to call out is the benefit reduction of 1.2. A lot of that is going to the bridge program, to the newest medical program. So that's kind of the good news. I'm going to check my notes real quick, maybe, if I can get it to do it for me, because I did want to call out one of the percentage differences. Yes, so this category of benefit reduction, I do want to call out that we were at 0.9, and so we have started seeing an increase. It dropped actually because we were holding OSIPM, right? Because we waited 4 months before we reinitiated the OSIPM population that was receiving OSIPM. And we are seeing an increase over the last month, which we kind of expected since we're starting to initiate. And again, that reminder that we did sequence across, and that the first few months for folks we knew would likely keep their benefits to allow for that longer runway for those that we were kind of worried that they would reduce or lose benefits. All right, Kelly, I think you have, I don't know who had their hand. Oh, Kelly, you are the only hand, so.
The only little hand. I think you said this, but I just want to be clear. The folks who moved from OHP to bridge OHP, are those all in the benefit reduction category? Because that seems like a small number.
I believe it is a small number, but
Okay.
you just called me on an error. So glad this is being recorded because I'll correct my words. It was not OHP to Bridge. It's actually OHP to Medicare Savings Program, MSP. I'm stuck on the Bridge. So if you let me restate this better, this reduction, primarily this small number is someone moving from OHP to Medicare Savings Program.
So with
OHP to Bridge is more comparable.
right. So where do those folks OHP to Bridge, are those just in the big renewals completed? Or are they in the benefit reduction? Which category, where do those folks sit in this chart, I guess?
Now that I caused confusion, let me go ask an expert and I will bring that back.
Okay.
But thank you for,
Thank you.
It was a perfect question because I gave you the wrong information. So I apologize. I knew I should have had my notes up the whole time. Let me find out. I owe you that question of where they represent in this chart, that when you went to the Bridge program. I will also say that the Bridge program, we hope to see an increase in more people being able to go to the Bridge program. The Bridge program came out at the same time of our pause, so we didn't see a high increase, right? Because we were pausing the renewals at that time. So these next few months will show us those numbers in a better and different lens. So thanks for letting me correct myself. Heather?
First, thank you to the whole team in the division, all of you working on the renewals and transitioning people to the new Bridge program. It's so exciting to hear that we really are, and I really believe this based on the work and your the whole group's dedication to continuous improvement, because we're having a totally different conversation than other states across the nation. And we're actually being able to dig into trends for people whose benefits are ending. So, I mean, that's a wonderful, wonderful place to be. It's a horrible thing for people to have benefits ending, but to be able to be in the place where we can actually have recommendations come out of how we can help them in the future as individuals and also change a larger population dynamic is really exciting. So I just wanted to say kudos to you and the whole team, and really all of us on the committee. Me, and I think we're just so excited about this. And so on that note, when you go back and tease out the Bridge program data, like how many people have moved to Bridge program and are their benefits pretty much equivalent, that would be lovely to know. Also, really, as a MAC committee member, would love to have some data on the trends in the benefits ending and benefits reduction. Is this people transitioning or duly eligible to Medicare? We know we here at the MAC, all of us from our various seats have experienced that difficulty in the community. We also hear from community members who are experiencing that concern. We know that that's a more complex situation, and would love to perhaps have more data to chew on what some ideas would be to move that needle for that group of folks and help them transition or get the services they need to stay healthy. And yeah, so I think that's a big one. So that's just my request to you all is I'm so excited about the progress you've made that I have deeper questions.
I know, right? Yeah. Progress means more questions, more thinking, more planning ahead of time. Yeah. Absolutely. A part of our, there's another slide I'll go over near the end, but a part of our closeout of this project is really lessons learned, best practices. And also, I think to your point, right? Like what is missing? What is the reason people have lost benefits? And then how do we turn that information into some actions for all of us as communities to start advocating and getting medical coverage for all, right? So thank you for that.
Thank you. Just to jump in, thank you so much for the presentation so far. So we are at the end of time for this presentation. So MAC members, We have the option of extending this conversation and putting off the charter bylaws conversation until December, or asking this team to come back to us in December. Are there strong opinions?
How much more does Christy Jo and
Sarah, let me know that there are 9 more slides.
We could take 5 more minutes, right? Emily?
Yeah, we can go through this pretty quickly.
Okay, great. Thank you.
Y'all, I am never slow. This is impressive for me to be that inclusive of my conversation. So thanks. All right, Emily, I want to turn it to you then.
All right, let's go. So next slide, please. Let's talk about outreach. We have 3 targeted areas that we are working on outreach for people. We have, and we're trying to maximize outreach and effectively reach people across receiving benefits across that. So we're doing direct outreach through targeted nudges by mail, phone, and email. We're taking an indirect approach, which is a broad awareness campaign across several different types of media. And then working with partners and equipping them to support outreach and amplify their messages. Some of the ways that we are doing that are the public and member-facing websites, which please go and visit when you have a chance, including the PHEU member webpage, the OHP webpage, the Oregon Health Insurance Marketplace webpage, and we do send out an Oregon Health newsletter for you to look at. Next slide, please. So for non-response, we are people who are receiving their renewal packets and have not responded after 30 days receive a reminder by mail from OHA. We're really looking at people who have not responded at the 30-day and 60-day mark. So once that happens, we get non-response reports that we then take out. We have PH Tech, which is calling members, especially the more vulnerable populations that we've seen in this 4th wave. We have case managers in APD and in ODDS that are contacting people directly. And then we are sharing data with on a monthly cadence with CCOs, Essentra, and Care Oregon. Next slide, please. So we actually have updated numbers on this. We started outreach to 12,512 MSP and OSM with closure dates starting in September. As of the 19th of this month, we have completed outreach for 2,580 members closing in September. And we will continue the outreach effort for the remaining members with future close dates. Next slide, please. We should recognize that 2 studies have come out recently which say that Oregon is near the top or is the highest in the highest renewal rate and the lowest closure rates that we are seeing out of completed renewals. And this data comes to us and is ever changing, but it comes to us from unwinding dashboards and monthly reports submitted to CMS. So I encourage you to go and look at those when you have a chance. Next slide, please. So let's talk about Bridge really quick. So Bridge is a new benefit for adults with higher incomes at between the 138th percentage and the 200% of federal poverty level. These are people that have to be under 65, between 19 and 64. They cannot have access to affordable healthcare insurance, and they have to be an eligible citizen or have immigration status to apply. It is free like OHP Plus, and it is almost the same benefit. Next slide, please. There are 2 types of programs with the same benefit package. The key difference between the 2 is that the basic healthcare program is managed exclusively by CCOs with no option for open card. And then the basic Medicaid program allows people to choose between CCOs and open cards. And they're only available to American Indian and Alaska Native individuals. Next slide, please. Thank you. This is enrollment as of September. We have 26,243 members who have joined the OHP Bridge program. Most of them have joined with a basic health plan, but we do have some members that are part of basic Medicaid plan. Next slide, please. So we expect 3 separate populations to be part of OHP Bridge over the next 3 years. We have persons who are moving. We expect about 11,000 people will be newly enrolled in BHP who've been previously uninsured. We expect to see more than 35,000 people to eventually move from BHP from the insurance marketplace. And then we have people who are moving over from the Oregon Health Plan, and they started to move over as of July 1st. And that is it. I'll pass it to CJ, please.
Thanks. So I won't spend a whole lot of time on this. We can definitely come back and talk more about this. We are starting to work through what does our project closure look like? What are the activities that we need to do to really to close out and make sure that we've got documented, to the earlier conversation, do some analysis of the data we have around closures. So really looking at how do we transition the conversations, the channels that we have created through the unwind so that we can continue those conversations across agencies and partners and communities, really documenting and making sure that we archive all the tools that we've created and what has worked well. We're also developing a final report to really, again, be able to have a document to provide with our legislative partners, anyone around the things that the pitfalls and the successes of this project. And then, we hope to really look at disseminating the information internally and externally. Again, just to celebrate the project and the amazing things that happened. Again, I stumble on saying wins because I think that the unwind has its concerns as well that we've already talked about. I'm uncomfortable saying there's a win when we know that there are families that lost medical coverage. And I thought I edited this slide and it didn't take my edits. And then we are also working through getting as we say, rolling back the one system, but honestly, at the end of the unwind will be the first time we've ever used the one system as it was originally designed, because we launched during the public emergency. So we will actually be restoring the one system to the original with lots of improvements design of how we support families. All right, I think our next slide is questions and answers. And I don't know if we have time. Do we have?
I think at this point we should just continue having discussion and put off the charters and bylaws until December. Thank you so much for this presentation. It is clear with the stats you've shown that there has been a massive amount of effort on the part of many team members to provide as many services to Oregonians as possible. I very much appreciate your language of not calling it a win, as it feels like a win, and also recognizing that for many individuals, it really isn't. So thank you so much. Lisa, I believe you had your hand up first.
Yeah, I just wanted to kind of make an advance point of something I'm going to cover from the ACE meeting is that Ellen Penny, the state ombuds, has raised the issue of the fact that people who have Medicare who are being disenrolled from the redetermination process are losing access to behavioral health, dental, and vision benefits in that process, and there's not a program in Oregon to cover them. So people who had OHP secondary to Medicare who are losing coverage through the unwinding process are going back to the basic Medicare benefits and are losing more benefits than a lot of other groups, other than those that are just being disenrolled entirely.
Thank you, Lisa. That is a very unfortunate reality in the category of not wins. Tony.
Yeah, I really appreciate the presentation. Thank you all. And what a great body of work to deal with a system that is imperfect. And I really appreciate the acknowledgements that we have much work to do. I think an acknowledgement that we have kept a lot of people on Medicaid is great, but we have seen a number of people that have moved over to marketplace subsidies, which are good for the ACA. But I think a recognition that those are incomplete as well, and continue to see unaffordability in that sector. Medicaid is a robust benefit package, and people are moving over to insurance products in that sector that are on the middle tier programs and often choosing bronze programs that are incomplete with high deductibles, with the majority of those being unaffordable for people to even access the care despite them having a plan. So I think us recognizing that, acknowledging that, and in the impact on those when we look at equity, that people these are unaffordable and are usually affecting families and communities that are disproportionately those of minorities as well and marginalized communities. So we have much work to do. So thank you.
But I appreciate.
Oh, please, Christy.
I appreciate all the thank yous, but I also want to return a thank you, right? Like this is my first time coming to MAC, and yet I know the work and the advocacy you all have done, and I appreciate it. And I look forward to continuing to how do we all empower each other to make changes in not just Oregon, but in our nation. So I look forward to future work as well. Thank you.
I think it's really exciting that we are being a leader in this area. I know we are struggling with coverage pretty abysmally in some sectors of our state healthcare, particularly in the behavioral health world. So it is really nice to see us doing so well in other arenas. Are there other questions for Christy Jo and her team? MAC members, any additional comment? There is, Sarah, should we move to break now? Should we take public questions? Can you help me here, please?
Sure. We could open it to the public if you want to continue until break time and make that opportunity available.
Let's do that since we have a few minutes. I see there's a question from Joanna Wilson in the chat. Joanna, would you like to unmute yourself or would you like me to read that for you? I'll read it. It says, I used to be on the F plan and decided to switch. Then I wanted to go on F plan with my insurance. However, they do not do F plan no more. They said go to G plan. G, is that the same as plan F? I get many retired people ask me this. Christy Jo, are you able to speak to that? Or is this about Medicare? I'm not entirely certain. I apologize.
Yeah, I don't know the details of that. Emily, is that something we could take back to some OHA experts?
Absolutely, we can take that back. We can document that question and bring it back the next time we come.
Wonderful, thank you.
Yeah, I'll just add, I'm going to guess that is around the CCO designation, CCOF, CCOG, which are benefit plans that include, oh, okay, maybe it's Medicare with Plan G.
Okay.
We'll take it back. We'll get a real answer.
We will have that available with answers later. Thank you for that question, Joanna. Heather?
I guess because we have touched on this and we have a little bit of time. I mean, we have heard anecdotally, and many of us have heard, and from both the professional seat and seeing where people are landing, and then also the MAC has heard directly from consumers about that intersect of Medicare and Medicaid, and so I'm not surprised to hear more questions, and so just curious. Is there thoughts from the team in analyzing that data on building relationship, or what could possibly, because I know Medicare is its own wild world, of easing that process, or more maybe just starting with low-hanging fruit, like more customer service, kind of what is the team's thoughts on this? Where are things at with that? And aren't we glad we have the opportunity to actually have space to talk about that? Because it's a big issue. So I'll just throw it out there. I apologize. I'm sure you have no immediate resolution.
I'm going to go first. I don't know if I can answer your question completely. because I'm not as familiar, I'm not as OHA equipped to speak to it as I wish I was. I will say from the ODHS perspective, we are actively working right now to provide additional supports to our eligibility staff to have the confidence and ability to provide that choice counseling, right? That has been a one of our weak points for quite a bit. There's been quite the swinging back and forth of where that choice counseling lands, and is fairly new. If 3 year, well, it really is new because of the unwind for lots of our staff. So just so you know, it's on my radar. My training team is actively working on some training components. We're also working on some video graphics, not only to help the person who is navigating those two programs, but also some scripts and some aids for our staff to be able to have more confidence in that conversation. I wish I could give you a date of when I think that we'll be better at it, but we are very much engaging in what are the best avenues to give that support. I would love, here's my hope, right? If we come back in December that we're saying, hey, we see some improvements, and can talk about the next steps as well. But literally just this morning, the updates have been made to some training materials, and we're and a video infographic was being worked on right now.
If you don't mind, hi, I'm Emma Sando. I haven't had my introduction to this group yet, but I am the new Medicaid director, and I think that this is a good call ahead of the Medicare open enrollment period to really remind folks around the important resources that exist to assist people through the I don't know if we call this SHIBA or SHIBA, but the resources available for I believe it's, okay, we're testing my acronyms here and I'm only 2 months in, Senior Health Insurance Benefit Assistance. That works closely with some questions that folks might have about Medicare, and there are a number of other resources at the state level, but also in the community to assist people with questions they have on their Medicare benefits, because oftentimes those do overlap, and we are approaching open enrollment on the Medicare side, as well as open enrollment on the Marketplace side. So it is a time where making sure that people get to the right resources is really important.
Thank you so much for joining us. We are thrilled to have you. We're excited to have you in Oregon in general, and also at this meeting today. Tony?
Yeah, I just want to give you another warm welcome. Thank you for that reference. I think that's a really important thing and resource for people. I think a call out to that is I'm a family doctor, and over the last couple of years have observed many patients with a lack of understanding of what the transition means for them. I will use a word predatory as far as advertising in that of Medicare plans, particularly in the space of Medicare Advantage, of the lure of certain insurance products, which leave many of my patients in anecdotal, but across the board, seeing large space where patients lack understanding of what the formulary is, or really what is the full benefits package that they're going to have when they shift in from one plan to the next. I've had many patients that I've seen for over a decade in my clinic, but yet find themselves in a narrow network, and therefore can't come to a community health clinic, which sees everybody uninsured, sliding scale fee, everything, and then end up caring for them via phone because they can't get into a provider because the network is so narrow. Then they also find themselves on a formulary where their medications aren't covered. And so I think any bit of information that we can empower families to make good quality decisions about coverage for the medications they need, the interventions that they require, is really helpful. So a great call out to those senior health insurance benefits of giving families and community a thorough understanding of what it means when they make transitions through different Medicare plans.
Thank you, Tony. We are now a little past time again, so let's pause and come back at 10:40 for an 8-minute break and get restarted. Thank you, everyone. Appreciate you all coming today. So as we said before, we are going to move the charter and bylaws review to our December agenda. Thank you, Sarah, for being flexible there. Apologize for my dog barking in the background, protecting me from a neighbor walking across the street. He is quite the guard dog. So we are moving on to the 2024-2025 work plan. And so Sarah is going to give a brief presentation on the draft work plan that goes through 2025. We'll get committee feedback and then vote if we're ready. So I will pass things to Sarah.
Great. Thanks so much. You can see on your screens the first page of the draft work plan. And I'll go over a little bit to orient people to it. I think our idea is to try to get us to a place where we are doing work plans that align with the fiscal year and especially with the biennium, right? So that is our goal, and we're partially there. And this work plan is proposed through December of 2025. Yes, what year are we in? And I we'll see how that rolls over into 2026 as we get closer to it. But in any case, here's what we're looking at. I've tried to keep this real simple with some simple visuals throughout to orient us to why these things are on the plan. With a reminder from our retreat that we kind of use this what, how, when framework to talk about our priorities during the retreat. And I want to have us continue to drive that through our work by noting those places where we might, in advance of a meeting, knowing that we're going to have a presentation on something, come up with the kinds of questions for those folks who are presenting to us to incorporate into their presentations. So you'll see a little caret symbol for all the places where I think that should happen. In addition, I've put little symbols for each of the things that are our priority work. So we've got a star for our Medicaid waiver, that is the 1115 waiver, a little square box for eligibility presentations, circle for our CCO procurement, and then a diamond for network adequacy, right? So, and then the last thing is kind of a teardrop, which isn't really a statement about this, about for our federally and state required work. So, as you can see, we've got quite a lot of things mapped out. And not a surprise, it's easier to see the things that we're going to have to do that are close up. And then as we go through the year, and if you'll scroll to the next slide, you can see we start to see fewer things, but that doesn't mean we're going to have fewer things to do. It just means that's all we can see at this point, right? So I'll back up for some highlights, I think. Throughout every month we're going to hear from the ACE and back. That's just a given, right? Every quarter or so, we're going to hear from the ombuds. That's a given. We do have a lot of ad hoc things. You'll see some question marks because we aren't quite sure of the timing of some of this, but generally we're going to get things like CCO marketing materials guidance. We're going to have a conversation about that. We are going to have conversations about quality strategy. Those dates are still being mapped out. We're going to have HRSN updates, as you heard from the team that was just here. They're planning to come back on a semi-regular basis. So we're still figuring out what those dates are going to look like. But those are the kinds of things that we are going to continue to hear about. In addition, we have, and I think I'm excited about it, we're going to have an update in January from the healthcare workforce, for example, which hits a couple of our priorities. And it hits our network adequacy priority, I guess. But it's exciting to me because it's cross committee work. We have an opportunity to talk to one of our sister committees about the work that they are doing. That work, of course, affects the network adequacy across the CCOs and across the system, frankly, in the state. And so I think it's just a example of the way kind of thinking through our priorities and really spending some time thinking through what we want to do through the year allows us to do kind of bigger picture work. You all have had a chance to sit with this at least for a week. Are there questions about anything on this work plan?
From my perspective, it is fairly straightforward and what we have been talking about, but of course, happy to hear other input.
Can you just remind me what the BUC is? I think that's what it was called.
Right.
That BUP, sorry.
Yeah, not a surprise. That one trips me up a lot too. And I don't think we've talked about it in this committee. It's the benefit update project. As you may know, and I'm sorry for putting an acronym in there that nobody knows, but as you may know, this is a plan that in the waiver, I'll back up. In the waiver, we have decided that the prioritized list is no longer really a waiverable thing. And so it's all the things that are on the prioritized list that kind of tell us what the benefits are that people are receiving are now getting moved over to a state plan amendment, right? So they're just going to be in the state plan. And the work to do that is happening in this benefit update project. And so that group was to talk to us because, as they should, consult with the MAC about that work. And that's what that's all about. I hope that helps. It's probably over explaining, but Heather?
I did not think that was over explaining. That was great. I'm really excited because Sarah, this is consistent with everything we've talked about over the months, and there's no surprises here. And I have to give you a little kudo. I love the little markers. I don't know what you want to call them, the stars, question marks, teardrops, and otherwise, because that really helps me as a member track, oh, wow, that's a state thing. Oh, that's a federal thing. Oh, that's a required thing. Oh, that's a waiver thing. Because we have so many different waiver items, which is so exciting because we have so much good progress in the state on coverage because of our waivers. But that's a lot. Those are things that we have to track as Medicaid advisory committee members. So it seems like a simple thing. I know it's not that simple, and it helps us to track and prioritize our work. So thank you for that. This plan looks very solid to me, with room for us to adjust our sales as we move forward in the year.
Thanks. Lisa? Lisa, are you able to come up?
Sorry. Yeah, sorry. Everything's covered up. I have this rolling closed caption thing that's covering everything up. Sorry. I'm wondering, so the behavioral health and substance use disorder treatment issue keeps coming up in ACE, and I know that we're going to talk about that in the ACE update, but we don't really have that on the work plan for the next year yet. So that's something that ACE is going to be hauling up. And I'm just wondering, do we want to try to make space for that now, or do we want to add that as a new item as we go along?
Sarah, do you mind if I do a little history keeping and brainstorm around that a tiny bit?
I think that's great. I would defer to the MAC members to respond to that question because it's staff. I don't feel like that's my decision to make.
Okay. Lisa, I love that. I believe in our retreat, and other MAC members, please correct me, but because the behavioral health and substance use disorder is included in actions that are in the waiver, and also actions in network adequacy that we're covering, we felt it was covered in that broader bucket of topic. Does that make sense? And then also because we knew the ACE BAC was going to also continue that, and also because we are hearing so much about that from the ombudsman report. So I think it flowed over into the larger buckets of the work plan, if I remember correctly. But maybe we need to have a narrative statement saying that we are aware of this. It flows over into several of these buckets, but that's my recollection. But good call out to make sure that we keep consistency and keep everybody aware as we're onboarding new members and all that good.
That sounds like a reasonable solution to me. I saw Lisa put a thumbs up. I had a more of a logistical question, Sarah, about the March, as somebody who plans my life months and months ahead. If there is a possible planning session, would that still be the last Wednesday morning of the month?
Honey.
Oh, if iPhone Joe could mute, please. So yes, just wanting to block my calendar as things fill up very easily. So wondering if that would be when we should block our calendars, or if there's a different Wednesday we should be blocking.
Oh, were you asking about if we were going to have potential educational sessions in months where we don't?
Yeah, just trying to tentatively block my calendar because otherwise things will go in it.
Yeah, that's a great question. Yes, it would, if we were going to have a potential educational session in one of the months, it would be, are we last Wednesday? I believe or fourth Wednesday.
We're the last Wednesday of the month. And so, okay, so that's when it would be great. Then I will make sure to reserve that time for potential meetings. Thank you.
Great. And that actually is a great reminder about a question that I had for all of you
for September.
Yeah. So in September, which I believe, oh, there it is. It's right on the screen. For September, our current date would fall on Rosh Hashanah, and that's a major holiday. So I would request that we move it to either September 17th or October 1st. We don't have to decide that in this meeting right now, but I will send out a poll to all of you. I just want to highlight it and look for that.
Absolutely support that. Thank you, Sarah. I think a poll is a great way to figure out who is most available for those other times.
Any additional questions about the substance in this? Okay. My goal and my ask is to have you all adopt this, approve it with a vote. And then I would suggest that we put it in our consent agenda just as a reminder each meeting that this is what we're working towards.
I'm happy to move that we accept the work plan, the 2024-2025 work plan, and that it be moved to the consent agenda for ongoing posterity.
This is Lisa. I'll second that.
Thank you. Any objections? Abstentions? The motion carries. Wonderful. Appreciate everyone's input there. So moving on to the Ombuds Report Subcommittee recommendation. So as a reminder, this is a letter to the new Oregon Medicaid Director, MS Sando, regarding recommendations in the 2023 Ombuds Report. Here is the memorandum. This was also sent to us in our pre-meeting notes. We reviewed this in June, the Ombuds Report recommendations, and then we appointed a subcommittee to bring recommendations to the MAT for action. So I will pass to MAT co-chair and this subcommittee member, Heather Jeffress, to present the recommendations. Thank you, Heather.
Hi, thank you, Caroline, and thank you, committee members, for taking time to look at this, and thank you to the committee members who participated in the subgroup, and of course, much gratitude to the Ombudsman staff and unit and all the really extremely important work that they perform for Oregonians. Thank you so much. So the subcommittee is happy to present this final letter for approval. I think that's what we're up to, right, Sarah? And there really shouldn't be any surprises in here for folks. We have heard the committee really held true and had great confidence in the items that were presented in the Ombudsman report. We felt that they were very thorough. We felt that they had been recommendations that had carried over across reports, which is unfortunate, but made it easier for consistency in our recommendation and really highlighted how important it is for us to support these recommendations so that we can get some positive movement and support everyone in working towards those improvements across the system. So you'll see, I won't take too much time to go over this, but you will see that the letter does very clearly in a box highlight the major key recommendations. And that is from the Ombudsman, one, enacting and enhancing culturally linguistic specific services known as CLSS in the lovely world of Medicaid. For dental, physical health. And you'll see there's a comment also and down below, there's a note because that is something that does exist. That CLSS modifier does exist in behavioral health, but it has not had the impact that consumers and providers in the system would have hoped for. So we do call out that it is a good model. It's a promising model and it needs continued support. to be effective to make those outcomes happen that we're hoping for. Also creating a new fee-for-service add-on for interpreter time, particularly with our health equity desire and drive. We want to make sure that we have good linguistic access. Linguistic access is pivotal for many communities, and we need a lot of work for that. Also, behavioral health networks. We know there are not enough providers. We know we have wait lists, and we know we do not have enough access across the state. And consumers are very much interested in this and concerned about it. And so are our MAC members. And then, as I mentioned, because the ombudsmen are playing such a pivotal role in continuous improvement and serving Oregonians, so that we can help drive the system in an ever improving direction. We agree with them. They need to be expanded and they need support, and they're doing excellent work. And we hope that they can continue to do more and keep up their excellent quality. And because they really are a direct source of consumer voice for the system. So, and they have done a great job of documenting that. So we really appreciate it. So those align with our priorities as you saw in our work plan. So no surprises. Yay, look at us. We're doing great work. No surprises. We like it. And that it also, we are pleased to see, aligns with the OHA strategic plan pillar. So we just feel really excited that we're all kind of on the same track. We may have different ideas about how to get there, but our big outcomes are cohesive. And so we're really pleased to pull this recommendation together and ask for your ratification so that we can send it forward to Ms. Sando, who is, I think, here. And so you're getting a preview of what you're going to get. Hopefully there's no surprises for you either. So with that, is there any questions about the plan or the process? We hope to continue, because ombudsman work is part of our federal requirement as a MAC. We hope to continue this structure. So we have the ask of you approving this, but I feel pretty good about the structure. I hope all of you do too. So with that, is there any discussion, comments before we move to approving this?
I appreciate the focus on the recurrent recommendations between reports and highlighting a more robust response. So thank you. Do other committee members have comments, questions, concerns? If not, I will ask, do I have a motion to accept the Ombuds Report Subcommittee recommendations to share this memo with Medicaid Director Sando? Am I allowed to motion, Sarah, as the leader? Or do we need somebody else?
I can make a motion to or second it.
Great. Tony, I'll
Tony,
take your
actually,
motion. Or can Tony
I'm
not
gonna
make a
jump
motion?
in. Tony, actually, as an ex officio member, cannot
Oh, that's right. I
appreciate
can't.
your willingness to do so. I think, Caroline, that you can. I don't. I mean, you're a member, so.
Okay. I will move to accept this memo. And do I have a second?
This is Jerry. Second.
Thank you, Jerry. Appreciate that. Any objections? Any abstentions? The motion carries. All right, moving on a few minutes ahead of schedule to the Advancing Consumer Experience Beneficiary Advisory Council update. We are going to hear about the subcommittee work since June, possible MAC action that will be taken, and I'm going to pass it over to Lisa Pearson, our ACE subcommittee co-chair, to present.
Hi, also, this is Lisa Pearson. So for people who don't know what the ACE is, we are the Advancing Consumer Experience Subcommittee of the MAC. We meet monthly on the second Tuesday of the month. If anyone is a consumer or is either a caregiver or a family member or an advocate for people with OHP, please feel free to join us. We always want more consumer voice on our committee. So this month we discussed a number of concerns. One that I've already alluded to is that, there is a lack of behavioral health access. Ruth is one of our committee members who is concerned about it being with seniors and people with physical disabilities, but it's really become an issue for everyone in Oregon. I think we all know how short we are on behavioral health access and substance use disorder treatment. We had mentioned that we thought perhaps that it was going to take some legislative action to improve access and to address these issues. That is something that we may be bringing to the MAC in the future, a recommendation that we take up and maybe put that up as a recommendation to OHA or other state agencies. We are still working on that recommendation at this point, so we're not at the point of making it yet, but we are considering putting up something around that. We had a new attendee this month who is works in a provider and says that their clinics are up to like 42% now of OHP patients, which is a lot of workload at low reimbursement rates. One thing around the reimbursement rates for substance use and behavioral health is that the reimbursement rates were increased recently by OHA, but a lot of providers apparently don't know about it, and so it's not generating the sort of increase in enrollment for providers into CCOs and into OHP, perhaps that we could be getting our bang for the buck for having increased those reimbursement rates. So that's something that we would like to see maybe MAC recommend, is that there be more outreach to providers that are not currently accepting OHP, that these rates were increased, and that maybe we can bring more capacity into the system to improve access quicker probably than any other method of trying to do it. Increasing workforce is a longer process, but hey, we've got more money, we'll pay you, is a lot faster turnaround time for new providers. I had a question about whether we had data by county on provider capacity by type. So does OHA know how many behavioral health providers per capita there are in, say, Douglas County versus, Multnomah County? We have someone looking into that at the ACE level, but that may also be something that MAC might want to take up, is, what is the availability of OHA data about current capacity statistics, right? By county and by provider type. It would be interesting to know if there are areas that are just in more dire shape than others, right? And then we had some consumers who talked about personal experiences about trying to find new care after they went on to OHP when they lost their prior provider from private insurance, and how they had to pay out of pocket, and how they were able to get their clinic that they were able to get access to actually enroll into OHP, so that they wouldn't continue to have to pay out of pocket, because that's what's happening is people that are coming into OHP sometimes, because capacity is so short, they are having to shoulder the financial burden themselves, even though they have OHP. The state ombuds, Ellen Penny, is always at our meetings and was talking about access to DME in Malheur County. People in that county don't have any access to DME, and that's durable medical equipment. try not to use acronyms, inside the county, and that the non-emergency medical transport services won't take them out of the county to go get those supplies. So that is something that Ellen's office is working on, but also maybe an issue for MAC is, if there are not services available in someone's region, can EMT, how do they access an EMT to go get those services somewhere else? Ellen also brought up the fact that, as I mentioned earlier, that people who were part of the public health emergency OHP population who are Medicare recipients are being unenrolled. And the result of that is that they are losing some OHP benefits, including behavioral health services, NEMT, and dental care, because they no longer are part of the OHP population. The other thing that came up also from the Ombuds office was that there is, as Ellen termed it, gross inequity in how CCOs are allocating health-related services flex funds. And so some of the CCOs, including my own, are putting those requests on hold because they are saying that they don't know how the new social determinants of health funding and climate funds and housing funds, are going to be available to those same needs. And so the flex funds are kind of being, in some cases, held up because they're saying the rules aren't clear about what other funds are coming down the pike. So that may be an area where MAC might want to be involved, or OHA needs to be involved in educating CCOs as to what the criteria are for these new funding streams, and also evaluating how they are currently handing out their flex funds. Ellen said that some of the requests are 6 or 8 weeks old for flex funds to some of the CCOs. And for a lot of people who are applying for flex funds, their need for those are immediate. So having this confusion, or the reasoning that we're not handing out flex funds because there might be other money and we don't know how that money is going to work, needs to be worked out. And one of our members also shared a personal experience with trying to get flex funds, and it also wasn't great. So we covered a lot in our hour and a half that we were working, and we will continue to work on bringing some recommendations up formally to the MAC on some of these. But for this month, we don't have a formal recommendation, but these are the things that we are working on. Does anybody have any questions? Okay, I'll hand it back. Oh, sorry, Heather, go ahead.
Lisa, has the ACE heard anything about, I know another opportunity for more flexible services, especially around peer delivered services for members, is around the in lieu of service benefit. Did that come up at all? Because I know some CCOs are leveraging that and some are not.
We have not discussed that. I haven't heard that. If any other ACE members are here that have heard anything about that, but that hasn't specifically come up in our ACE meetings. One thing that I'm working on in the Mid-Willamette region is that we are, both Lane and Benton counties health departments have stopped seeing outpatient mental health services. And, for Benton County, that is a huge blow to our access because they are our main provider. Lane County has, not that Lane, it doesn't also hurt Lane County, but Lane County has more private organizations and nonprofits that provide services than Benton County does. We also have the OSU population. Now, of course, Lane has U of O, but when those students come back, we double our population here overnight. And so, we already are so short on access, and then you add 35,000 people who need access overnight. And they're not all OHP members, but a lot of them are. And it's a very, very dire situation. And, it's something I've been trying to work on locally, but I really do think that it's going to almost take legislation to try to move the needle on this. I mean, Oregon's been in the bottom of the barrel on behavioral health and substance use disorder access for a long, long time. And so that is something, that's the main thing. But I haven't heard the issue that you're discussing so far, but I'm sure we will.
Thank you very much, Lisa, for the conversation. Heather, great questions. Are there other MAC committee member questions or comments from members of the subcommittee?
I see Sarah dropped a link in the chat for CCO resources.
Well, great. Thank you. I'm moving back to my notes. I think where are we? We're a little ahead of schedule. Am I right? Yes, we are. It's 11:16 and our next isn't until 11:30. How do people feel about starting the charter bylaws conversation, or what are people's thoughts? I get a thumbs up from Heather. Sarah, are you prepared to circle back? Lisa's also giving a thumbs up. And we can maybe at least start the conversation and
yeah, I think this
in
is
December.
quick and we could circle back to that.
Yeah, let's have an initial section. So scrolling back.
Jordan, can you take us back? It's gonna be, yeah,
Great.
4 slides near the beginning, right after the public health emergency unwinding update.
So this is the charter and bylaws review. We're previewing the existing charter and bylaws and trying to identify and address areas to align them with new federal rules. And right. Sarah has these suggested changes, as well as there is another document that was sent to us with her edits and questions. So I'll pass to you, Sarah.
Great. So I'm gonna concentrate. I think, Jordan, if you'll help me out, there should be 4 kind of PowerPoint slides that look like PowerPoint slides. That's what I'm really going to focus on. And if you don't have them, I do. And there we go. Okay. So next slide, and we'll start there. So just as some background to get us on the same page, as we know, the Centers for Medicare and Medicaid Services put into place an access rule that became official in July of this year. It has to be fully implemented by July of next year, at least the sections that we're talking about. There are other things that are out of our bailiwick. And then at the same time, we also are still, working on full implementation of House Bill 2992, which calls for compensation of committee members. So those 2 things mean that it's really time to revisit our charter and bylaws and potentially state law, but that's a whole nother thing that we don't have as much control over, right? So next slide, please. So I've shared with you some comparison documents and some thoughts about how we might rewrite our bylaws and charter, just to get us started thinking about that. But I think this can't all come from my head. So I need help from the committee about how we're going to go about rewriting our charter and bylaws. And my suggestion is that we create a subcommittee to work with me and other staff that subcommittee would meet for about an hour a month through March, if we need to go that long, to put together a draft, that we would present a draft charter and bylaws at our April meeting for discussion. And then we would vote on the draft charter and bylaws at our May meeting. That would, frankly, that timeline would give us wiggle room if we didn't get it done by then, to have another chance at it at our June meeting, so that everything would be in place for July. So that is my proposal to all of you. Next slide. I think it might just be a discussion slide. There we go. So I will open it up to discussion. I know that was pretty brief. Let me know what your thoughts are, and what I've left out, that so it doesn't make any sense at all. Lisa?
So, Sarah, does the discussion for the MAC changes to the bylaws also need to include anything around how the ACE is going to become the back? So, for those of you who have no idea what I'm talking about, our Advancing Consumer Experience Subcommittee, CMS made a national requirement for states to have a consumer advisory committee for their Medicaid programs. And so, since we already have the ACE committee, we are going to transition that into being the Beneficiary Advisory Committee. Is that the new title? Is that what BAC stands for, Sarah? Pretty
Beneficiary
much.
Advisory Council. Y'all get to be a council.
Beneficiary Advisory Council. So we're going to be the new Beneficiary Advisory Council, which means we're going to be a standalone committee and no longer a subcommittee of the MAC. So how much is that going to impact how the MAC bylaws change?
Yeah, I think it will have an effect. I think we know that there are some things we know that we will need to change in the charter, just because of the rule, regardless of what the Beneficiary Advisory Council does. For example, we'll have to put something in the charter or bylaws regarding the number of members who need to also be, or the percentage, I should say, of members who need to also be Beneficiary Advisory Council members. But I think it is important also that these be kind of parallel processes. I think that the MAC cannot wait until the Beneficiary Advisory Council is stood up to make changes to its bylaws and charter. So they need to happen together. Which when I say together, I mean in consultation with each other. Does that make sense?
Yeah, that makes sense.
I think the proposal you've created, Sarah, for having a subcommittee is a great idea. I did have just a couple of questions of looking at the comparison charts of the old version reported determination, including costs and affordability, which were not noted as specifically in the new version. And then curious what your thoughts or other MAC members' thoughts are around the change of term in office due to the, I'm not going to get it quite right because I don't have it right in front of me, but I believe you said I believe in your notes, it said the federal government requires no consecutive terms. So is the thought, and there was also a comment in there about the co-chair term for the same purpose. Are you thinking of because my understanding currently is that it's a 2-year term, can be renewed once, is the idea to switch it to a 4-year term?
That's my first thought. And
okay.
So essentially what the rule requires is that we cannot have members serve consecutively. However, we can decide how long, every state gets to decide how long terms are. currently it's written into law that they're 2-year terms that can be renewed. So again, this is why I think we need to have more discussion so it's not just coming out of my brain, but that's, I think that's where that's coming from.
Do committee members have other questions right now or feel like this is a good place to leave it to head into subcommittee work?
I concur, Caroline, based on the kind of the real specific criteria, and that was a really good example that you shared. I support a subcommittee to work through the requirements and then what actions need to be taken to make those requirements actuated. Is that the right language? For the MAC, because it sounds like there might be some statutory recommendations. Is that correct, Sarah?
Well, there statutory recommendations.
Like on the term, if the term is in statute, then that's something that would have to be recommended to be changed because
correct.
Different now.
Yeah.
Okay.
Do we need to have a vote to create a subcommittee? Or can we just decide that? Based on the notes you sent me, it looks like we can just decide that. Are there any current volunteers for this subcommittee? Also, please volunteer now if you are gung-ho to join. Otherwise, Sarah, if you could please send out an email recruiting participation, I think that would be most effective.
Will do.
Great.
Anybody gung-ho? Nobody loves charters and bylaws? No.
Sarah, will you make sure in that email communication that the timeline that I think was on a prior slide is included so we can assess capacity?
That would be very helpful. I know I am quite interested, but I am pretty overextended at the moment, so I don't know that I want to commit to something I can't do well. Okay, so we are 3 minutes away from public testimony. Do we, I know we like to have that exactly at 11:30. Do we have any comments for these 3 minutes? Other brief discussion that anyone wants to begin? I know we have MAC discussion at 11:40, but if anybody has a brief comment, question, we can get started on that now. Or if anybody has a great joke, always like to smile. Nobody's taking me up on the jokes. Shocker. Okay, well, or we can just pause for a few minutes and be off camera for a minute. Why don't we do that? We'll break till 11:30 for just a couple minutes and then come back on at 11:30. All right, it's 11:30. If people want to rejoin, hope you got a moment of stretching or yawning. I know I did a big mouth yawn, jaw stretch and body stretch. So thanks for those couple minutes. So moving on to public testimony. So the Medicaid Advisory Committee welcomes and deeply appreciates public testimony. It is one of the most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means that we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will also not interject to correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, and listen with careful attention, respect, and honor that you deserve. We want to acknowledge that time held in our meetings to hear public testimony is meant to provide a voice and perspective from that individual and is not a representation of the Medicaid Advisory Committee, its members, the Oregon Health Authority, or Oregon Department of Human Services. Each presenter is given 2 minutes to share. In the event that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help keep us on time, we will start a 2-minute timer for each commenter. We kindly ask that commenters conclude their presentation when the timer is complete. Please know that written and verbal public comments will be reviewed and discussed following each meeting by the board chairs and staff to determine the appropriate next steps. Board staff will communicate the next steps with each public commenter. In addition, please note that we will share any testimony regarding the 1115 waiver with the Centers for Medicare and Medicaid Services in OHA's quarterly report to that federal agency. Are there any public comments today?
I'll just note, we got a very last minute public comment, which we have posted on our website. I will also drop a link to it in the chat. And I have not received word from anyone wanting to give public testimony today, but I will, of course, we invite public testimony at this time.
I will give people a couple minutes to read that public testimony and see if anybody else has public testimony to offer. Courtney Johnston, did you have a public comment? Well, I want to thank Rachel H. publicly for her public comment in the form of a letter submitted. Are there other members of the public who would like to speak?
Caroline, I think you're still on mute.
I am so sorry. I was asking if anybody else had public comment, and I was thanking Rachel for her written testimony. And then I was starting to say that if there is not any additional public testimony, we will move on to our MAC discussion. So as a reminder, during our retreat, we offered a set of equity questions to keep in mind when making policy recommendations. Sarah sent these out again Monday or Tuesday. We suggest that we add them to our consent agenda to be reviewed prior to each MAC meeting by each member with a vote of the community. Sarah, are you able to pull up those questions just so we can briefly review them? Or I can attempt to find my email that has them.
First, I have to find the unmuting button. Yes, I can do
So
that.
So questions to consider, just to read them. Does the proposed policy or program change specifically affect or address populations who have been historically underserved versus groups populations in general? And there are sub-questions. Question 2, does the solution proposed by the policy or program change work towards eliminating barriers to accessing necessary healthcare services and/or benefits? With sub-questions. Question 3, does this solution involve identifying and reporting on health inequities or health equity? With sub-questions. Question 4, are there community partners that should be engaged in considering this policy or program change? With sub-questions. Question 5, how does the policy or program change incorporate any requirements for community engagement during the implementation period? Question 6, are there any changes that could be made to reduce or eliminate negative outcomes and increase positive ones for affected populations? And finally, question 7, given the responses to the questions above, to what extent does the proposed policy or program change address OHA's goal of eliminating health inequities by 2030? Are there any questions about discussion about adding this to the consent agenda before we vote, Heather?
I just want to comment that I think this is a really wonderful item to move to the consent agenda, just to remind all of us, and then also to support onboarding of new members to the work that we have at hand based on our work plan and how many things we have to make sure that we're implementing. And I think that these questions really get back to our kind of focus, as Sarah said, of what, how, where, and that we really stay focused on health equity. And I appreciate this, and I love the moving it to consent agenda to keep it fresh in our minds.
I agree. I know for myself, I think it would be a helpful lens refresh to read before each meeting, just to reframe how are we looking at the topics being brought to us at each of these very full meetings. What other thoughts, questions, concerns do other members have? Do you have another thought, Heather?
I did. I'm sorry. I'm hogging question time. Also, we will include these in the kinds of questions that we ask for our presenters to address when they come and do presentations to the MAC. That's correct also?
That sounds great, Sarah. If that could perhaps be sent to presenters to be thinking about as they're preparing their presentations for us, it would probably help guide some of their presentation and decrease some redundant questions that we will be asking at every time. Other thoughts? Well, if there are no other comments, questions, or concerns, do I have a motion to add these equity questions to our consent agenda?
This is Kelly. I will make that motion.
This is Lisa. I'll move that we accept them.
Great. Thank you, Kelly and Lisa. Are there any objections?
Caroline, you're back on mute.
Can you hear me now? Because I didn't click it. Okay, sorry. And so thank you both. Do I have any objections? Any abstentions? The motion carries. If there are MAC members who would like to speak at this time, please raise your hands. Any other questions? Otherwise, it might be a first in my time of being on the MAC in almost 2 years of possibly ending early. Last takers before I pass off to Sarah. All right, well, I want to thank everybody for their time today, and I will pass the meeting closure over to Sarah Weatherson.
Great, thanks. Well, I might mess you up because I have a couple things to talk about from staff perspective. We wanted to let you know that the non-emergent medical transportation technical advisory committee is looking for new members. I'm going to drop the details in the chat. Applications are due by Friday if you want to share these out with folks who might be interested. So I'm just mentioning that here. And then I will yeah, this is going to take a little work. Then the other thing I wanted to mention, oops, that's too long. Did you know there's limits to how much you can put in the chat? I'm finding this out. And in addition to that, I want to remind folks about the survey, the demographic survey for MAC members. Lots of you filled it out, but we still have some gaps that we want to fill.
To interject there.
Yeah.
How do we know if we filled it out and don't remember if we filled it out? Should I just fill it out again? I don't, because I honestly not sure if I have or not.
Gotcha. I'll tell you what, I'll do some follow-up with each of you individually because I don't want to
be awesome. So
call
please,
anybody out in the group.
If you're able to tell those of us who have not done it, that would be great because I would happily fill it out, but I don't want to duplicate if this was something I did a month or two ago and has slipped from my brain.
Sounds great. So look for an email from me following this meeting. I will let you know individually whether you filled it out or you haven't filled it out. And if you haven't, I'll share with you the information about how you can. Thanks. And then I also, and this is open to everybody, member or not, we'd love to hear from folks about how the quality of the ASL and Spanish interpretation services that we're providing in our meetings. So we have a survey for that. Some folks may have had a chance to fill this out in the past, but we wanted to be sure we're actually talking to the people who might be using it by bringing it up in the meeting. So I'm going to, again, lots of stuff in the chat. I'm going to drop this in the chat. We've got links for the survey in both English and Spanish. The survey will ask you about both ASL and Spanish language interpretation. Love to hear from people about how that is working for them.
Sarah, there were comments earlier in the meeting regarding ASL interpretation. Looks like Joanna Wilson, perhaps if that could be sent directly to her since because it looks like she had to jump off.
Will do. And those are questions that we will follow up on and bring back.
Great, thank you.
And I see that Emma Sando is here. I see that she commented that she's looking forward to getting to know us better, which is great. I don't want to put Emma on the spot, but also since we have a minute, I thought I'd open it up if she wanted to say hello.
Sure. Thank you, Sarah. And hi, my name is Emma Sando. She, her. I guess technically I have a PhD, but you don't need to call me doctor in this group as I still don't know who that is quite yet, but I'm very excited to be your new Medicaid director. I come most recently from North Carolina, so I've been very excited to no longer be in the humidity and heat of North Carolina summers, which last about 9 months. And I understand that the rainy winters here last about 9 months, so I'm trading off a little bit of different types of weather. But I have loved every moment living in Oregon thus far. I spent some time in Boston and Washington, D.C., but originally hail from the West Coast, so this really feels like coming home for me. And have been so excited to get to know the team and working in Oregon Medicaid. I have a lot of experience with eligibility and enrollment related issues. So really enjoyed today's presentation on unwinding. I led the unwinding efforts in North Carolina, as well as Medicaid expansion, which y'all did many years prior to North Carolina, but we were excited to join the ranks of Oregon in providing more health insurance in North Carolina. I, on a separate note, worked very closely with our version of this team in North Carolina and helped get the establishment of the Beneficiary Advisory Committee as well. So this conversation has all been really wonderful and music to my ears. I am going to try as much as I can to attend as many of these meetings as I can. As you probably know, I'm in back-to-back meetings all day, every day, but want to make sure that I have plenty of time to meet this group and join you all, as I think it's the most important thing we do is to make sure that our program is meeting the needs of the people that we serve and the people that are part of this group. So I'm looking forward to working with all of you.
Thanks so much for letting me put you on the spot there. It's great to have you here. And so I'll just ask my final question in the spirit of continuous improvement. I want to check in about what went well and what you would change about today's meeting. So we'll start with what went well. Lisa?
Yeah, I just want to say these meetings are really informative, and I think that we're making progress, and I think that we have a lot of broad voices here, which is always great. I'm going to add something to the Delta just while I'm on here, is that I wish we had more public comment, and I think that part of that is our meeting times and our the fact that most Oregon Health Plan members don't even know about us.
Thank you,
Hi,
Lisa.
Joe Rosado, just to tack on to that as well. I'm both an employee of ODHS as well as a parent who does know about this committee, and I've spoken before, but particularly when you said, is there any public testimony? And there was this great silence. I literally thought to myself, well, that's very intimidating. And I can only imagine that someone without any self-advocacy skills would be very intimidated by that opportunity. So I'm not sure how to address that, but I do know that the formality of this meeting, which is absolutely necessary, and I really thought that the timing of this meeting went very well. But as a consumer or someone who'd want to provide testimony, if there was any way that you could maybe coach someone, excuse me, or something like that, it might be a less intimidating, like more of a listening session format. I'm not sure what the answer is. I just know my visceral reaction was that was very intimidating. Thanks.
I'll jump in. This is Caroline, the co-chair. Thank you so much for saying that. I know these environments can be incredibly intimidating. And I know when I am sitting amongst even some of my peers in these policy sorts of roles that I can be very intimidated. So I really appreciate you saying that. I will chat about how to make it more inviting. As a just off the cuff thought is that truly we are not looking for formal policy informed thought out responses. We are hoping for just real lived experience and what good things you're experiencing, what challenges you're having. And we are really not expecting anything formal or prepared, just your authentic experience of these benefits.
Thanks, Caroline. I totally agree. I do. When I'm talking to other parents who are happy to share their stories with me, coming to a place like this and sharing their story is a different animal altogether. And again, I don't know the answer if it's a different kind of an invitation or maybe some instruction on, hey, do you want to tell your story? This is a place to do it. I do know that because I used to work with Ellen Pinney at the public health department, I had her ear on many of the unfortunate issues that a person with IDD and a fee-for-service open card issues. And that was actually why she started the DME think tank and the DME listening sessions, because she couldn't believe the stories that I was telling her. And I'm a fairly good advocate. So if someone like me, who's educated, speaks English as a first language, understands the system, was having difficulty getting parts for a wheelchair for a growing child for a year, then what would happen if it was any one of those vulnerable populations who didn't have any of those advantages? And that's what came about the DME rule changes. So, but it was really an informal conversation that got us to that point. So anyway, just my 2 cents.
Well, thank you so much. We will definitely think about how to be more accessible. Just again, as an off the cuff thought, sometimes people find the written testimony to be easier. But we will definitely can talk about whether or not we could offer listening sessions. I know in my clinical experience with patient focus groups, those have been very helpful. So thank you. I'll pass back to Sarah.
Great, thanks. Unless there are other comments about improving the meeting or things that went well, I'm going to suggest we close it out. And with that, seeing nothing, hearing nothing, I will thank everyone and remind folks that we will meet again in Portland if we have enough people on the committee who can come in person on October 30th at 9 a.m. We'll keep you posted if that needs to be virtual, but we'll hope to see you on the 30th at 9 a.m. in Portland. Thanks.